With us for the second show of the Synapse video shows, we have the head of Pathology Department, Dr. Christopher Barbara, who will be speaking to us about the local antimicrobial resistance and the treatment to respiratory tract infections. Welcome, Dr. Barbara.
Hello, Gabriel. Thank you for the invitation. I'm a microbiologist myself and a virologist as well. So basically today we'll be talking about some infectious diseases.
Our first question to you today, Doctor. We've known that antimicrobials, antibiotics, have changed the way medicine is practiced. They started being used in 1930s, 1940s, but in the last 2 decades, they've started to wind down in their efficacy because of increasing antimicrobial resistance. What can you say about local factors in this regard?
Yes, actually, you're very correct in what you're saying. The problem we're getting with antimicrobial resistance is, unfortunately, a result of their success. But not only as a result of their success, because they are being used so much today for most infectious diseases, but also because the antibiotics have to be used very wisely in the appropriate situation, at the appropriate dose, and for the appropriate duration, the length of time we're being given an antibiotic. So actually, first you have to see what infection you're dealing with. If you're dealing with a respiratory tract infection, whether this is an otitis, etc., or whether this is a pustule on the skin, etc. Then you have to know the prevalence of the organisms which can cause that particular infection, not only in the global world, but also the local pattern of etiology for that particular infection. And finally, you have to know the resistance pattern in that particular country or the locality where you are practicing.
And your role, your medical profession, gives you access to invaluable information about the types of antimicrobials which we must use and the strains of microbes we have to deal with in our local community. What can you comment about that?
Yes, of course. For every particular organism which we have in our country, we're going to see a changing resistance pattern for that particular organism. For example, since the time penicillin was used, one of the first patients who was saved was Mrs. Miller, for example, and we used to use ampicillin outrightly throughout this country. This was at the time of the war, 1942, during that period. We've had so many successes with the penicillin since the time Alexander Fleming had first discovered its properties. But today, we don't use ampicillin anymore on its own, or we don't even use it, because we know that there has been emergence of resistance to all these particular antibiotics. And this is all the time changing. So we have to know exactly what's happening in our country at the moment. For example, Streptococcus pneumoniae. We know that more than 30% of our strains are drug resistant to the most common penicillins. So this is DRSP, drug-resistant strep pneumonia. We know that besides knowing the pattern of resistance, we have to know where the antibiotic is going to concentrate. If we're going to use an antibiotic which concentrates in the lung, we have to see whether this is going to concentrate in the interstitial space or whether this is going within the cell, intracellular. So if you're trying to eradicate a Streptococcus pneumoniae, I wouldn't go for a macrolide, which concentrates in the intracellular space, but I would go for a beta-lactam penicillin, which concentrates in the interstitial space. So all these rules of thumb, the doctor has to keep in mind all the time to get a success when he's treating an infection. So this is all very important.
And with that in mind, what 3 main organisms worry you the most, let's say, in the lab?
It depends which infection we're talking about. If we're talking of respiratory tract infections, yes, then I would think of Streptococcus pneumoniae, because this, besides being one of the commonest, is the one which is the most dangerous. Okay. Then we have the Haemophilus influenzae and parainfluenza. And finally, we have Moraxella catarrhalis. Before we used to call this Branhamella catarrhalis. And at the time, we used to think this was a commensal in the lungs, but today we know it is a pathogen and has to be treated. So it's very important that we know, take the commonest organisms for the etiology of a particular infection, in this case, a respiratory tract infection, and target the antibiotic or choose the antibiotic which targets these 3 or 4 main organisms so that we can't go wrong. And then if there are some atypicals for example, community-acquired pneumonia, and you have to add a macrolide and so on, don't give that on its own, but add it to the previous antibiotic. So if we have to choose an antibiotic for a particular infection, the choice of antibiotic is important, both because of the etiology we have, both because where the antibiotic has to concentrate. And then we have to look at the local community and the resistance pattern in this community.
And in your case, you have in your department invaluable information about local resistance patterns.
That's right.
How regularly is this updated, and is it available to the medical professionals?
That's right. Yes, this is updated regularly because today we have software and automatically this goes into software. However, you have to extract the data to see what type of data you require from the system. So this is something which was not happening in the past. But today, thanks to our interaction with the clinicians, etc., so during presentations, we do present this data in local scenarios, in local continual medical professional development, etc. And I think we're taking this as one occasion, one opportunity, whereby we can start transmitting this data through the Synapse.
And right here today, what local trends can you speak about, an overview?
Yes, of course, looking at respiratory tract infections, we can look at every particular organism. So we can take Streptococcus pneumonia, for example, and we can see that the beta-lactam antibiotics work quite well over here. But if you look at the macrolides, for example, there's lots of resistance, okay? However, there is still some resistance, and there is still some resistance even to beta-lactams because of a dosage problem. The antibiotic has to be given at quite a high dose to prevent the emergence of resistant strains. So it's important to give a good dose of antibiotic for the appropriate time. And then you can go into Haemophilus influenzae, for example, where you can see that beta-lactams are working quite well as well. You can use third-generation cephalosporins, depending whether this is a community-acquired pneumonia or not, or whether it's just an acute bronchitis, okay? You also have the newer respiratory quinolones, which work very well. If you're suspecting an atypical, things like Klebsiella, things like Mycoplasma, you can, of course, add a macrolide to the other first-line antibiotic.
And one last question. So the prescription, the selling of antimicrobials from the pharmaceutical outlets has been controlled now. Nevertheless, we are still experiencing certain resistance patterns.
Sure.
How do you predict the future in this regard to be?
This is always a battle between the bacteria and mankind. We have to be very wise in the choice of the antibiotic. What I fear and used to happen, maybe less today, is that a lot of people used to take an antibiotic without this being prescribed by the medical profession. Today we know that this is being clamped down with the help of the pharmacists, but of course we are consuming antibiotics not only by it being prescribed by the family doctor, but also the veterinary field. The animals have large doses of antibiotics and we consume those. We also have domestic pets who are given antibiotics, and you get emergence of resistant strains if these are treated inappropriately. Always remember that if we do not give the right antibiotic with the right dose for the appropriate time, we're going to select a resistant strain, and this is going to spread in the community.
One last appeal to the general medical profession out there who are following this program.
That's right. I think it's very important through this medium, this being one of them, for example, they continue their professional development, their professional education. And this is by following the local resistance patterns, what we have here in Malta and Gozo, so that when they come to prescribe an antibiotic, they know the antibiotic really well, and they know the sensitivity pattern which we get in our island. So it's useless using an antibiotic which is resistant, for example, to DRSP, drug-resistant strep pneumonia, when you know it will not work. Because if you give that dose of antibiotic, you're selecting emergence of more resistant strains. So choose your antibiotic wisely, okay, because it's very important to know the etiology, know your local sensitivity pattern, but once you know that particular knowledge, you have that knowledge, the right dose for the appropriate duration of time, depending on the infection we're talking about.
Thank you, Dr. Barbara. I now invite all medical professionals to keep in touch with the Synapse for more information in this regard, and we will be with you in the coming weeks to bring busy medical professionals the information that matters. Thank you very much.